Good morning, everybody. My name's Mike Burrows. I'm the AHN Network Coordination Director, and I'll be hopefully trying to chair and host the event this morning. Thank you very much for coming along and giving us a couple of hours of your time. I think we've got 2 hours in the diary. We may not need all that time, but I appreciate everybody's very busy, so thank you very much for joining us today. Just a few bits and pieces of housekeeping first. We are going to be recording this session and it will be available on Tinternet at some point in the future with a bit of appropriate editing of the both ends of the event. So just please be aware that we are recording. You are all automatically muted, so you won't be able to shout comments out unless we allow you from mission control at this end. But there is the questions function, so you can pose questions throughout the event. So we'll try and pick those questions as we go along. Depending on how the questions come along, I may actually introduce some breaks in between the individual sessions, and we'll try and gather up the questions at those points and answer them as we go. Just breaks up the rather than being spoken to in presentation mode all morning. Okay, so those are the bits and pieces of housekeeping. Hopefully everybody can hear us. I've noticed one comment in the question saying someone cannot hear us. I suspect that may be a problem at your end. If anybody else is having those problems, just flag it up. So, but I think we can hear one another, and I've noticed somebody else has also said they can hear us. So hopefully the volume will be okay. Okay. The National Wound Care Strategy Programme has been in existence 2 years now. I won't go into the detail of it. I'll pass over to our Programme Director, Una, to talk about that. But we felt it was a good time now to put an event on like this to share both the progress we've made and to flag up where we intend to go with this piece of work, but also to use as another opportunity to get insight and feedback from you guys. We do have a number of stakeholder and engagement avenues into the strategy, and we've had a lot of input and comment from people around the country, both clinical practitioners, patients, industry have been quite active, and colleagues in academia as well. But we're always keen to keep on listening in terms of picking up bits and pieces to finesse the piece of work as it progresses. We've got a couple of speakers today. Una Adderley, our director from the National Wound Care Strategy Programme, and Jacqueline, who's the programme lead for data and information, and we will be spending a bit of time talking about that. I'm going to be talking about how we move forward and implement the recommendations. We were hoping to have Dr. Leanne Atkin, who's a lecturer practitioner, vascular nurse consultant, both at the University of Huddersfield and Mid York's NHS Trust. She's been unable to join us this morning, but fortunately we have her presentation material, and both Una and I have jointly presented with Leanne before, so we'll share some work that Leanne's been doing up in Yorkshire, in Mid Yorkshire, and some great results that have been achieved there that we can tell you about in due course. Okay, without further ado then, I'm going to hand over to Una now, who's going to just set out the case for change. Una, over to you.
Good morning. I'm hoping you can all hear me, and if anybody can't, please type something in and let me know. I'm really grateful you've made time this morning for this, because I know how busy everybody is, but it is such an important topic, so we're very pleased to have so many of you. I was slightly stunned to realise how many of you have signed up to this webinar, so thank you very much. I hope you appreciate we're using some technology which is less familiar to us, because we did anticipate there'd be quite a large number of you. So apologies if a bit, and it's no criticism of mine, but if it sometimes appears a little less like mission control, a bit more like Apollo 13. But we will get through this, and we will hopefully get the information to you that we want to, and be able to listen to your questions and hopefully answer some of those. Right, next slide, please, Simon. Some of you will be familiar with this. I'm just going to do a whistle-stop tour of the programme. it was commissioned a couple of years ago now to develop a national wound care strategy for England that focuses on pressure ulcers, lower limb ulcers and surgical wounds. We appreciate there are lots of other different types of wounds out there, but these are the ones that are the biggies that are causing the most misery and consuming the biggest amount of resource. So we were asked to particularly focus on these. Now, the pressure ulcer work is Stop the Pressure, which at the moment is still a programme aligned to the programme rather than sort of within this programme, but we work very closely. Lower limb ulcers and surgical wounds. And I think the shocker for most, well, maybe not less for those of us who've worked in this world for a long time, is how big the lower limb ulcer problem is. And we're talking about foot and leg ulcers here. So we have been working away for the last couple of years, working towards a strategy to improve this, because it's not going to be a quick fix, because if it was, we'd have sorted this already. So far, we've developed some clinical recommendations for the care of people with lower limb wounds, which is what we're going to be concentrating on today for most of the presentation. We've also got one in the pipeline for surgical wounds as well, but that's will hopefully be finalised towards the end of this year. We've developed some free-to-access online education for clinicians who are not wound care specialists. In other words, people who do wound care as part of their normal work. People went for GPs when people present to them, for student nurses, for people who deal with wounds, but they're not specialist wound care people. We're in the process of developing a multi-professional, multi-capability framework. That work should be done by next April. We have developed a draft wound product classification system, and we're also, some of you will have been involved in the consultation recently for the output-based specification for mobile data imaging and data capture technology, the wound management digital systems that are the apps that are starting to appear. But we're now starting work on implementing the lower limb recommendations. And why are we focusing on this first? Well, it's the biggest proportion of wound care in terms of spending clinician time. It's prior to COVID, I was being told it's between 30 to 50% of community nursing. I'm now told it's between 50 and 70. I haven't got any robust data to be able to say it's for that, but it's certainly a very large proportion of work. It has a huge impact. We've got a strong evidence base as to what works, and we've also had that for some years, and we know it's not being implemented well across the country. So we know there's huge opportunities for improvement here. And so to address this, we've put together a business case, and that's some of which I'm going to be sharing with you this morning to talk through what we think is possible. Next slide, please, Simon. Now, I've sort of whisked over this anyway. Sorry, I got ahead of myself here. As I say, we've already done some work around data and information. We're looking at the key data items to improve quality improvement. You really can't do quality improvement unless you actually know what you're measuring. I've mentioned the wound management digital systems. I've mentioned the product classification system. We're making recommendations about education. We are proposing that anybody working at advanced level of wound care, tissue viability nurses such like, ought to be educated to master's level. I've mentioned the free to access online education modules. All this stuff can be found on our website. We're also looking at developing a 4-day curriculum for clinicians who'll be working in the leg ulcer services that we're proposing. And that will be mentioned as we go through. And I've mentioned the core capability framework. Just while I've got your attention, just to let you know that we remain extremely interested in supply and distribution of wound care products. However, we were in the process of just starting some work on developing recommendations for what organisations need to think about when they are commissioning such services. However, obviously when COVID arrived, the people we're working with got pulled away to deal with PPE, then it was dexamethasone. I think now it's flu vaccinations. I've been trying to get a booking for one of mine this morning. No chance of getting a flu vac for a month for me or so. So at the moment, we've suspended that supply and distribution work to hopefully next April, when we're hoping that the people we need to work with will have some capacity to do that. So it's not we're not interested, it's just in the current climate, there's only so much you can do. And that's our situation. Right, next slide, please. So let's turn to the foot and leg ulcer situation, what the focus of our work is for this webinar today. I'm guessing a lot of you, this won't come as a surprise, but it might to some of you. If we look at foot ulcers, we know that diabetic foot ulceration is a big, big problem. But what a lot of people haven't realised is that, I'm just wondering, okay, is that there are as many people with foot ulcers but who don't have diabetes as do. And as far as we can tell, the outcomes are as bad, if not worse, for that group of patients, which maybe isn't surprising because I know the diabetic foot service is not perfect in every area, but at least there's usually a service. There should be a service. People without diabetes but foot ulcers fall through the gaps too often. So we need to be doing something about this. The leg ulcer problem is absolutely huge. The estimated cost for 2019, we reckon is around 3.1 billion per annum. That is massive. Most of it's due to venous disease. And at the moment, we estimate less than half heal within 12 months. And of those that do, a large number recur within 12 months. So unless we improve care, the prevalence of total leg ulcers is expected to increase by about 4% a year. That's a big increase. And what's interesting is that although aging is a factor, which this question I always get asked, yes, aging of course is a factor, we have a growing older population, but actually most of this growth is being driven by inadequate care in that ulcers are not healing and are recurring far too often. So next slide, please. Some time back, some of you may remember Betty's story, which was a good piece of work that was done by NHS Improvement, which looked at the cost of leg ulcers and made the argument that we really need to be doing something about it. But unfortunately, that improvement just hasn't happened. The classic story is typically a patient will present to their local GP, who will refer to somebody like the practice nurse or the district nursing team. The trouble is patients need a full vascular and neurological assessment, often involving secondary care and podiatry. And a proportion of those patients should also be referred for endovenous ablation or revascularization, or both. And that appears not to be happening. Patients are having to wait far too long to be seen, either because they're being referred to people who either don't have the knowledge and skills to do this, or more commonly, they might know what needs to be done, but they haven't got the capacity. And I mean the time capacity. And I mean, I'm a district nurse by background, and the classic story I keep hearing is you've got a load of patients you've got to see that day. One of them is terminally ill, is dying, is in pain. You've got to do something about that one. You've got somebody who hasn't had their bowels open for God knows how long. That's obviously urgent because they're in pain. And so your leg ulcer assessment, yet again, falls off the list because there are only so many hours in the day. And that situation will get worse with COVID because we're getting more patients coming out. So we have got to do something about this. We've got to close that gap between patients presenting and getting the right care. That seems to be, as far as we can tell, where the problem is. Right, next slide, please. We are putting forward a proposal that we think there needs to be a major change in how we look after people with leg and foot ulcers. We think we need to think of changing the model of care provision. And I'm aware that some people around, and some people on this call may already be well on their journey to this, and congratulations to you if you are, but too often it's not happening across the country. We think we need a rollout of dedicated chronic lower limb wound care services. And the people delivering that care need to have the appropriate education, which is the 4-day specialised course we're talking about earlier in my slides. And we also need to make sure we've got educational materials to support self-care. We are not talking about turfing people out to do this by themselves. We're talking about people actually having the knowledge and information and access to information and dressings they need to do as much as they can themselves, but with the support of the specialist people. And these specialists may not be tissue viability nurses. They may be nurses who are working within, or podiatrists or other clinicians working within these dedicated chronic lower limb wound care services. If you do something a lot, you get good at it. And if you've got the protected time to do your job properly, you can make a decent job of it. That's what we think needs to happen. But the other thing that is incredibly important will be data and information. As I mentioned at the beginning, if we don't have the right data and information, we don't know if we're improving. So we think we need rollout of point of care, NHS compliant mobile digital technology. In other words, when whoever it is delivers the care and they record that care, as you will do normally anyway for the care you are doing, it goes straight into a system that can be shared with other clinicians involved in that patient's work. And it should be done at the point of care. those people caring for leg ulcers shouldn't be having to do double entry. People shouldn't be having to come around doing paper audits and everything else. We should be able to have a streamlined service. The systems exist, we're not using them. That needs to change. And we think if we do this, we will then shift towards evidence-based care, because we'll have care delivered by clinicians who know what they're doing, who are delivering that evidence-based care, and we will have funding and pathways so that there is care across the services, because patients will move from maybe a care home to their GP, might be the district nurse, it might be the practice nurse, or it might be the referring into the, say, specialised wound care clinic, who then may refer to secondary care for whatever care they need there. Patients with leg ulcers and foot ulcers need seamless care across all our different providers. It's not just a one provider problem. Next slide, please. I mentioned the problems we have so far about the poor care that we're seeing at the moment. We don't have robust data on foot ulcers, but we do know that there are serious risks of people not getting care, and access. There's a few areas that have set up at-risk foot clinics, and they appear to significantly reduce the risk of major lower limb amputations at 12 months. I read somewhere it was halving. This is huge. This is what patients need. And if we turn to the leg ulcers, particularly the venous leg ulcers, which we know are the biggest number of patients, at the moment, as far as we can work out, across the country, and this is an average, I know some of you will be getting much better rates than this, but on average, only 32% are healing at 12 months and 46% recurring at 12 months. So this is national figures, so averaged. But we estimate, having done quite a bit of work on this, that it should be achievable to get 74% healing at 12 months and only 18% recurrence at 12 months. And these are quite conservative figures. And again, I know some of you listening will already be achieving much better than that, and I will go on to that in a minute. Next slide, please. So what's the impact if we implement the recommendations that have been made in the lower limb recommendation document? We estimate within 5 years, which is quite quick, we can get a 30% annual reduction in leg ulcer prevalence and a 15% annual reduction in the cost of leg ulcer care. And if you think that we estimate at the moment we're spending 3.1 billion, that is a big lot of money. And by 2030, it should be even better. If you look at the graph on the right, this is where we think the savings will come in. And you can see the 1, 2, 3, third and fourth is the biggest blocks, and that is mainly down to compression therapy. Now, endovenous ablation is also important, and it is cost effective, but it is a much smaller benefit. But the compression therapy is what will make the big benefits. And these figures include the cost of implementation, which you can see is the column on the far right. And also they've been calculated within Treasury guidelines. So these include 30% optimism bias. So we are being, as I say, conservative with a small c, and yet we still think these figures are achievable. Next slide, please. If we bring this down to ICS STP level, and again, these are estimates, but if you look at this graph, as I often say, I think this is my favorite graph because it made my jaw drop when I first saw it. You see the little V that's pointing downwards, that it will cost some money in the early days. That's the cost of implementation, but look at the size of the savings, which is the big cliff face to the right. And we've calculated this over 2 years. So this is quite a quick return. And there's a benefit cost ratio of 10. So for every pound you put in, you should save £10. This is quick, fast, and should save a lot of money, along with a lot of suffering. Next slide, please. I'm not going to spend a long time on this. I appreciate there's a lot of information in this slide, and we will be posting these slides so you can go back to them. But this is what we've looked at. The setup cost for clinics. We're assuming you've already got Doppler equipment because that's what people are telling us. So there is a cost, but not a huge cost. We are assuming that you will not be recruiting large numbers of extra staff, but we'll be reallocating some of your staff to go and actually deliver care within the services we're talking about. Some of you may have social care models, things like the leg clubs, and those are very cost effective. And so those of you who don't might want to look into that. We have costed in the clinicians who would attend the training, actually, we've costed in their time as well. We've costed in software costs. The biggest cost by far is program support, and we are going to be able to contribute a bit towards that. We won't be able to do the whole of it, but we will certainly be wanting to support you. But you will also have your own implementation people within your organisations. And we're also speaking to the HSNs, whose raison d'etre is implementation. So, and we've also got other organisations in the NHS who are very interested in this piece of work. So we really hope we can draw implementation support from a number of areas. And then, of course, there'll be monitoring and evaluation costs. But actually, because we're expecting to do point of care data input, those should be negligible and actually will be included within the programme support costs, which is why that's at 0. Next slide, please. So where are the savings coming from? A large proportion will be around workforce productivity. We are not suggesting you will be cutting your nurse times, community nursing times, because let's face it, community nurses are up to their necks as it is. But the difference will be they won't be spending nearly as much time, 30% less time on wound care, which means that time is freed up for all the other things that we would like community nurses to do. But there are also some cash releasing savings around drug prescriptions, hospital admissions, and wound care products. So it's both cash releasing and workforce productivity. Next slide, please. Huge benefits for patients, greater mobility, more time for work and leisure, just all the things you'd expect from when you get a horrible wound on your leg healing. But another one that's interesting, we haven't costed these, by the way. There are some costs around, but frankly, they're huge. We didn't think anybody would believe the business case, so we put them in. There are some quality costs around. But the other one that was brought to my attention, I think is really valid, is this would really improve morale and job satisfaction for clinicians. There's a lot of clinicians out there who know what should be done and cannot deliver it within the current system. So not only would you be improving quality of life for patients, you'd be improving quality of life for your staff as well. Next slide, please. So if we look at exemplars from practice, these are just some of the things that some of the organisations I've been chatting with have been telling us. Really, those which are getting ahead on this are finding big improvements. Bottom left, the Manchester amputation reduction, they're finding their appropriate referrals have improved, and they're also getting much better outcomes. Accelerate in the middle, they're getting 99% of people diagnosed with the venous ulcer are in compression, and 65% healed by 12 weeks, which makes R74 in 12 months look pretty achievable, doesn't it? I'm trying to think. The one I love is the one of the leads at the bottom. Thank you for turning me into a normal human being with normal legs. People shouldn't be having to suffer like this when there actually is an answer that will make sense. So I've just given you a taste of what's possible here and from a variety, but I just wanted to run you through the Wakefield work that might refer to at the beginning. I know there are others of you doing great work out there. I happen to be familiar. If you can just put me onto the next slide, please. Thanks, Simon. But I just want, this is an example that was shared with me a few weeks ago. And what's really impressed me is this was set up during COVID. This started on the 2nd of June. So since the 2nd of June, this is a one-stop, once-only assessment clinic that's been set up in Mid-Yorks. It's staffed by a vascular nurse consultant and who oversees things. And I believe it's two I think band 6 nurses and healthcare assistant. Now, what's interesting, they are only seeing new ulcers. And I was a bit sort of, oh, but is this equitable? But actually thinking about it, their argument is that in order to get ahead, they've got to make sure the new people are seen first, because then they can get them set on the right path. And that in itself will create capacity in the rest of the system. So that's their rationale. I can see their arguments. At that first stop, they do a complete vascular assessment. They assess the need for venous, surgical, endovenous interventions, refer on as needed. They give a diagnosis. They set up the treatment plan. They start compression. They promote and support, enable self-supported management. They make sure the patients go out with all the supplies they're going to need for the next month, and they make any onward referrals. So it's very much a wraparound service. Next slide, please. And I've just tried to put this into a graph to show you what happens. So a presentation on the far left, that will be maybe to the GP, the district nurse, whoever. Care home, I don't think they're taking care homes yet, but in theory that could be done. but that person picks up the phone and makes a referral to the clinic. So anybody can make that referral in. They then get their assessment. They expect to see feet within 48 hours, legs within 14 days. And as I say, they get the care I've just outlined. They then get a package of care to help as many people as possible look after themselves at home. And somebody said to me, wound care is about the only long-term chronic condition they can think of where clinicians do all the work. Whereas any other, like diabetes, anything else, patients are taught to look after their long-term chronic condition. So where possible, they get people to look after themselves with a bit of support as needed. And of course, if necessary, nurses, registered nurse to visit or see the patient. They review on a 4-weekly basis with a registered nurse to make sure things are progressing. And of course, if there are problems, people can come back. Right, next slide, please. So what are the results? What are they seeing? They've seen 116 patients in 3 months. The average time from referral to assessment, remember they said they want to see people within 14 days? The average is 4.3 and the longest has been 12 days, which I think is remarkable. I'm amazed how many people are venous, huge proportion. If you look at the bottom left-hand pie chart, most are venous, and 90% of the patients with venous leg ulcers are in strong compression. So we're talking about 40, none of this fiddling around with mid-compression, they're getting them into strong compression. But interestingly, only 28% are in compression bandaging. And the rest, if you look at that graph in the middle, the rest are in systems that stand a good chance of either they can do themselves or with the help of a carer, they can manage their own compression. Only 8% are requiring regular registered nurse input. And that's not the 4-weekly input, that's the going to help them with their dressings. Only 8%. And only 5%, which surprised me, have been referred to vascular. And given that this service is run by a vascular nurse, I think we can hope that most of those referrals are appropriate because you'd expect them to be. So they're certainly not withholding vascular, but there's not a bigger demand as they thought there would be. But this is only an example on a small sample. Next slide, please. The impact. They've gone from 87 patients a week needing 87 patients a week needing registered nurse visits down to 8 patients a week. And this is across their patch. They're getting 37% healed in 4 weeks. And their patient satisfaction is extraordinarily good. So patients love this and they're getting really good healing rates, which suggests they're doing something right. So again, this is early results. And I'm aware some of you also are doing some very good work in this area, but I wanted to share this with you because I think it makes the message. This is the right thing to be doing. The people in Wakefield happen to have been involved with the programme since the beginning. So they've had an early eyes on what we've been going to propose and they decided to get cracking. So this is interesting, this can be done. What they will say though, is they haven't done the data and information work. And that's what they're hungry for next. Because in order to get these results, they had to trawl by hand through all the electronic records to pull all the data. And they know this isn't the answer long term. So it's great they've cracked the clinical side, but there's still work to be done on getting the data and information in a much better format. And they haven't yet gone into the care homes. So that's another area. Right, I'll shut up and I think I'll hand over to Anne, Professor Anne Jacqueline. Now, Anne, we have a slight technical problem that all the internet's gone down in Anne's area this morning.
Just before we hand over to Anne, there've been a few questions coming along, and I think it might be a good point just to take those questions.
Certainly.
Okay.
You'll have to read them.
I'm going to read them out to you, Una. Let me just go back. So, right, I've got a question here from Jennifer Townsend. If there aren't endovenous ablation services locally, will this mean we can't then be involved in the implementation?
Hi, Jenny. Nice to speak to you. No, not at all. What we are planning with the implementation is how do we get access to such services? Because you will be able to access somewhere you may not have at the moment, but that's part of what we want to learn. So not having access to any particular service doesn't stop you applying, because part of what we're trying to work out is how do we get that sort of issue sorted. Thank you.
Okay, the next question is from Joe Dunville. Hi, Joe. It says, do you mean self-care, self-management or self-treatment? I think it's important to make sure what is meant by self, that the self term, as it's not always the same thing to the same people, including patients. So just clarify that point.
There's about 6 different terms in use at the moment, and apparently I can one-up you, I can top trump you, because apparently the latest is personalised care. What I will say is we're already in conversations with the personalised care team about this very issue, and the work that we will be doing in terms of the education and everything else will be making sure that we use the best possible approach to support patients to look after their own wounds as far as possible. Now, I'm sure my terminology isn't perfect there, but I can assure you we are going to be working with the experts, and that's going to be part of our working out our implementation over the next 12 months.
Okay, there's a question from Nasir Ahmed around data, and we'll come back to that after Anne's presentation. A couple more clinical questions. From Lucy Hall, is the lower limb wound clinic in addition to a specialist DFU service?
That's also a very good question. That will be very much up to areas to work out what works best for them. We are not planning to, the only thing we are going to really push is that whoever works with us has a good, wants to embrace data information and upholds the principles outlined in the lower limb recommendations. How you do that is part of why we're trying to do this work. Sorry, remind me of the question, Mike. What was the nub of the question? Sorry.
Sorry, just pull it back on my screen. Where are we? So I'm just scrolling down the questions to try and find this again. Is the lower limb wound clinic in addition to the specialist DFU service?
Right, coming back to the back. We have been in conversation. Thank you. We have been in conversation with the diabetic program. On the one hand, they wish to be supportive. On the other hand, there's lots of challenges around capacity for the diabetic foot ulcer work as well. So we are not going to say that it has to be part of the diabetic foot ulcer service. There seems to be disagreements within the profession as to whether it should be or shouldn't be. And I think that's for areas to sort locally rather than us say. It might be complementary, it might be integrated. That will be one of the things we will be seeking to untangle and work out what are the options.
Okay. Question from Carly Morrison. How is tubigrip classed as compression? We have spent so long telling people it is not appropriate, and then it is being labelled as compression in this presentation.
Yes, I think tubigrip, we're not talking about a single layer. There are tubigrip type systems. And I think, I don't think Leanne's on the call, but by all means, if you want to pick that up with me out of the meeting, I can certainly put you in touch with the Wakefield team as to how they deal with that.
Okay, Carly. So next one is from Narelle Mills. Are there lower limb wound clinics all over England? I'm in primary care. Increase of ulcers is huge. We do Dopplers, then refer to secondary care, which sometimes is up to 10 weeks wait for our patients. Gosh.
Yes, that's exactly our concern. They are, should we just say, scattered, but they are not, and we think this needs to change. So that's exactly what this is about. 10 weeks is not acceptable. My own father-in-law had to wait 6 months, so that's definitely not acceptable. So we need to do something that gets people there much faster, because all that's happening during that 10 weeks is patients are deteriorating. You do your best, but we need to be tackling that. And as I say, we're not coming up with a ready-made quick solution. We know this is not straightforward, and that's why we want to work with some organisations to start to work out where the issues are and how we solve those sort of issues.
So I think the answer, Narelle, is that the strategy will be recommending that lower limb wound clinics are established across all of England. That's correct, isn't it?
Yes.
Okay. Question from Ian Chetter. Should assessment include venous duplex?
Yes. Again, I think that has to be done on a patient-by-patient basis. Certainly, patients who would benefit from any sort of vascular endovenous type intervention ought to be referred to people who can make that assessment. So I think at the moment, too many patients are not getting access to care that would benefit them, and we need to do something about that. So I can't answer that every patient should have a duplex, because obviously it very much depends on the patient. But that will be something, again, we need to work out, and maybe we need to develop some more recommendations, more, we might be able to work out some criteria, some referral criteria as part of this work.
Okay, next one is from Polly Cox. Hi, Una, you talk a lot about community nursing services, but these patients are housebound, so regular attendance to a clinic is difficult. However, those going to practice nurses would be more suitable for clinic attendance, How do you propose we manage the housebound patients? Good question.
Really interesting question. I would agree with you until I started to see some of the data. It is amazing how many patients who are housebound can actually get to a clinic for an assessment. You're right, not all of them can, but a large proportion can. And it is surprising how many, obviously you would not expect people to come to a clinic who are housebound on a frequent basis, if they genuinely can't manage. But it is surprising how many can manage with the help of a healthcare assistant who's been taught how to apply particularly things like the hosiery and the other solutions. And you've got to remember the patients, if we see people early, I've deliberately not put any horror pictures up on my presentation. I'm trying to move away. But we are talking about getting people early before they get to this horrendous stage. And so if we can treat people much earlier, we won't be seeing as many of the terrible wounds that we're seeing at the moment. So you're right, we will still need a visiting service. You're quite right. But we are seeing that there are a much larger number of patients can get out than we previously thought. And that's not just the Wakefield data. I've seen that from other services as well.
Ian Chetter's come back after the question on venous duplex. It said, if you don't look for it, you won't find it. You've already stated 90% are venous. A good point.
I will be pulling you in on that work, I can promise you.
A question from Yaping Lian, or is it Lian Yaping? I'm not sure. Hi, Una. If the secondary care would like to be involved, do we need to get the community on board?
Yes, in a word.
Yeah.
We're looking for organisations that want to work together and start. You've got to work together. You cannot improve care unless we start thinking of ourselves as a unified service. We've got to find ways.
Yeah. And final question from this section before we hand over to Anne. It's from Sarah Fentiman. Where does lymphedema fit within these recommendations?
Yes. If you look at the recommendations, we do refer to lymphedema. We had a big discussion about this because we are the National Wound Care Strategy. So technically, we couldn't cover lymphedema on its own. And also, it's a big topic in its own right. But if you look at the recommendations, we make lots of, we do comment about lymphedema, and we say patients who have, well, lymphedema, in fact, it's swelling, which most of these patients do, ought to receive appropriate care for their swelling. So we do, again, we would encourage organisations coming forward. We need to start thinking about links to lymphedema services as well. And you're absolutely right.
Okay, if you've got any further questions, just batch them up and we'll come back to them in due course. Right, at which point I'm going to move over to Professor Anne Jacklin now, who's led the data and information work stream of the National Wound Care Strategy Programme. Anne's going to give us an update on how that work is progressing and the relevance in terms of the recommendations and implementation planning. Over to you, Anne.
Okay. Thank you, Mike. Just checking, can you hear me?
You went a bit faint then, so if you stay close to your phone.
I'll stay close. I will speak as loudly as possible. Is that better?
Can hear you fine, yep.
Okay, so thank you, Una, and thank you, Mike. Simon, can I have the next slide, please? Okay, so I think I've only got 3 slides to try and congest the whole of our approach to data and information. So for those of you familiar with IHI and improvement, you'll know that in order to improve something in improvement science, you've got to be able to define it and measure whatever it is you want to improve. And so what we're interested in is talking about what do we want to improve and what data do we need to support that improvement. And what we've got here is a slide that gives you an idea of what we mean by data. So we're predominantly interested in patient data. So following what Una's been talking about, what we're really interested is in outcomes. And going along with that, then we need to understand volumes of activity. We need to be thinking about how we capture diagnosis. We are interested in referrals, referrals not only into vascular surgery, but also between healthcare professionals, either within community, primary care, but the question was, if you're in secondary care, do you need to work with community? The short answer is yes, but I'd extend it to say we're actually interested in looking at implementation sites across the patient pathway. So that's about primary care as well as community care, as well as secondary care. And we know the burden of caring for these patients falls in the community, and depending on your setup, will sit in primary or community care. And so you get a sense of the type of data we want. We believe that we can release time to care and release staff to do their jobs in a more effective way if we improve the way we care for these wounds and use evidence-based care. And we will be also looking at product use and equipment, although they're not really on our agenda till next year with our supply and distribution group. So we're mainly focused on patient data, and recognizing that data, though, has what we're referring to as two distinct purposes, if you like, and we've divided that into business and clinical. So Una has referred to, we're going to be recommending point of care data collection, and we've got here an underpinning principle that we need to move to data collection being secondary to operational practice. We no longer can have data collected on paper to be entered at a later date, nor have clinical staff diverted from providing care. They need to be supported by technology that supports their practice, provides clinical decision support, and the data is collected secondary to them doing the work that they need to do anyway. So point of care digital support will help provide continuity of care and provide decision support. We can remove the need for some of these really time-consuming audits, and we can begin to drive improvement because we can look at how we are treating patients again across a pathway. So we're interested in not just community, but also primary and secondary care. But we know that a lot of time is spent in all sectors, but particularly in community services, managing contracts and commissioning. And we know of some tissue viability nurses in community trusts who spend a lot of their time collecting or trying to collect key performance indicator data to manage their contracts, to manage their services. And if we're going to do business case development and performance management, we really need some data, and that is sadly very missing, particularly in community, but also in primary and secondary care to some extent, to be able to show patients across a clinical area, a geographical area. So if I can have the next slide, please. So that's the purpose of data. Can I have the next slide, please? Thank you. Okay, so in addition to thinking about the different types of data, we're giving a lot of thought to where and how do we want to use data. And we realise that there are different levels, if you like, of data that use. We are a national programme. We're interested in driving improvements in the care of quality and outcome rates at a national level. This means that we need to work at a national level with national existing data sets. So we're interested at looking at, in secondary care, at hospital episode statistics or SUS data, secondary uses service data. In community, we're interested in looking at the community services data set. At the moment, we're not aware of a full primary care national system of data, but we know that if we work at an integrated care system level, there are a growing number of local healthcare record records being developed, some from the local healthcare record exemplars, but some that are happening locally in local patches. And we're very interested when we work with our first implementation sites to identify people who are working, inputting data and actually getting some data back out of their integrated care system level, as well as working with our sites to look at the quality and the standardization of coding that happens locally. Well, the volume of data collection that happens locally, which is extremely variable depending on the current systems in use, but also which codes are used, what's the consistency of coding, how well community and primary care have developed their SNOMED codes for wound SNOMED CT terms, so that they're feeding in a consistent set of terms, so that we can look at maybe a patient journey within integrated care system, or at least in different sectors from our national records, even get to volumes of patients in community. People may be surprised to know that at the moment we cannot tell NHS England how many pressures ulcers or lower limb wounds there are in community services in the country, and we need to be able to move to that and as a minimum start. But of course, as you work in larger national data sets, the amount of data you send up is relatively highly aggregated, and what you want from a clinician's point of view is a lot of granularity in your data. So we imagine and we view the way we look at data is that at a local provider level and at a clinician level, you will need much more data for a clinician level to enable your continuity of care and clinical decision support and detailed audit and improvement. You'll need more aggregated data to do your service management and some of your contract management. Your integrated care system, again, you might take a subset of data, and then going up into the national systems, you'll have another subset of data. So we see data as increasing granularity across the system, but we will be wanting to consider best use of data at all of these levels. Can I have the next slide, please? And so this takes us to what are our priorities for this year and then on to next year. So we have now as a programme got some resource so that we've got an analytical partner so that we can begin to examine existing HES and SUS and CSDA data. So these are the national data sets, so that we can look at what is available now on referral rates, patient numbers. Can we do any work about the amount of time that people are in care? In secondary care, the data set is a little more advanced in terms of length of stay and admissions. Of course, there is not clinical coding in outpatients, so there's a complication in the amount of data you can get out of HES if people are running, say, outreach outpatient services. It will depend on how clinics are named. So there'll be a lot we need to do in looking at existing data and the data quality. And we're assuming that on our first cut of looking at data is likely, quality is likely to be poor, but that we'll, by getting it about looking at data, sharing it back with our first tranche implement sites and others, we'll be able to work together to improve the data quality. And we have a mantra, which is use it to improve it. And so when we start to feed back data, people then get an interest in how do they improve the quality, what is it that they haven't understood about the use of the data that means that there's an improved way to collect it. And that includes, I've already mentioned, the need to standardise SNOMED CT in community and primary care. And that leads us to, if we really want to get to the art of the possible, we need to not do what Leanne and her colleagues did in Mid Yorks, which is to introduce a great service and then spend days sitting at a PC looking up individual patient records from clinic lists to work out what was the change in outcome for patients. That was an entirely manual process, which is not sustainable within Mid Yorks, never mind as a national programme. So we do need to move to much more broader adoption of wound management digital systems. There's a healthy and developing market of different suppliers. By wound management digital systems, Una mentioned app, but we're thinking much more broadly than an app. An app is what you need at the patient, at the point of care. And so somebody asked earlier about what do you do for the housebound patient? Well, if you've got a housebound patient and your carer, your caregiver has an app, can take a photograph, maybe a video, can have that uploaded to a web-enabled system. They can then have, in theory, a live chat with somebody in the clinic directing. The data then can go up into some software that tracks the patient over time. And if, for example, our clinical navigation tool for lower limbs sets various time points, like, I don't know, a wound is present, and if it's still present after 2 weeks, it needs to enter the pathway. Then, of course, if you've got some decent software that tells you, hey, for this patient, they've now triggered 2 weeks, they enter the lower limb pathway. If that then triggers, say at 2 weeks, by 2 weeks, they should have had an assessment. If that has gone into a clinic booking system, but say somebody's at home, a home visit can be arranged. But also it means that by exception, somebody managing the service can look for people who are coming close to their time limit for the next activity and manage that service better. They can prioritise, and they can prioritise over the time that a wound is healed. And so we are talking about point of care data capture, which is used not only in clinics but ongoing at home, and that can be used by clinical staff, by non-registered clinical staff, potentially some areas of the country looking at local authority caring staff to get engaged, but also patient self-care. And so, as Una mentioned, we just had a consultation on our functional overview specification, which we'll be doing some work on to put out a detailed output-based specification so that we can be clear to the NHS what we mean by wound management digital systems and where we see them fit into good pathways of care and how we believe they're vital to the improvement journey and releasing resource and time to care by getting the improvement but reducing the amount of time people spend on data collection. And so that takes us to, Mike will be coming in more detail about what is happening about our first tranche implementation sites. One of our criteria will be that we're looking for people who already have got and are using wound management digital systems, but if places don't have them but are willing to adopt them, have plans to adopt wound management digital services, then we think these are essential in order to be able to collect the sort of data that we need in order to be pilots and blueprints for the rest of the country, and also to help us work out in terms of granularity what subsets of data should be going to national data sets, what is the best use of your ICS level local healthcare record system, and how do you best use outputs from that to do your joined up services locally. We know that we want to work with the first tranche sites to sort out the data quality, get the coding standardized, and find out what are the practical issues interfacing with the patient administration or electronic patient record systems, which of course is essential to have two-way flow of data to reduce the amount of data input that anybody has to do in the nursing home. And then we want to, from those sites, start to develop the quality improvement metrics, which are going to be time to heal, use of resources, whatever. But we'll be working with first tranche sites and then looking to see whether we can work with our colleagues at NHS England and NHS Improvement to make those part of the growing model healthcare system that sort of is the business as usual methodology that's used by the Get It Right First teams and the improvement teams and the existing infrastructure for improvement around the country. And that's the model that was previously the model hospital and is now called the model healthcare system. So we see data and information as central to the work of the programme, so that we can not only drive the improvement, but measure it, and most importantly sustain it and make it business as usual in existing NHS data and information infrastructure. And that's the end of my presentation. Thank you.
Thank you, Anne. We've got 3 peachy questions for you here.
Go back to you, Mike, I think.
Yeah, can you hear me, Anne?
I can hear you.
Great. The first question is from Nasir. Have you considered who owns the data regarding wounds? If we buy an imaging system, it has implications for audit and evaluation of products. Can you hear me, Anne? Did you hear that question?
I'm sorry, can you repeat the question?
Have you considered?
No, can you repeat it?
Have you considered who owns the data regarding wounds if we buy in an imaging system? It has implications for audit and evaluation of products.
We not specifically at this stage focus on evaluation of products.
Are you there, Anne?
So much of what we've covered so far is about. Sorry? No, we're having problems, aren't we? I'll try and dial in.
Sounds like we may have a delay on the line slightly, but Nasir, I think the question you ask is a good one. It's part of the work that Anne's been doing around the specification to make sure that the data that's captured by the apps and the systems is, gosh, some background noise there, translates into the NHS data systems. I think that might be some background noise we're getting from Anne.
Right. Can you hear me now?
Yes, but you're echoey.
Right, I'll leave the webinar. Is that any better?
Much better. So,
okay.
Right, I'll repeat that question. I was attempting to answer it, but you're better to answer this question. It's how have you considered who owns the data regarding wounds if we buy in an imaging system? It has implications for audit and evaluation of products.
Well, yes, who owns the data? The NHS owns the data because we will procure, as we do with any other digital system, the data will be locally held and fed into the national system. So yes, we own the data, is our vision. With regards to the evaluation of products, that's not the primary use of the data, and most people locally, it depends on the volume of patients they have, how much they'll be able to evaluate one product off against another. That's much more about volume at a research sort of stage.
But there's a key issue here. Key issue here, Anne, is that making sure that as part of the specifications for system, we ensure that the NHS has the ability to transfer that data to its systems so it can access and interrogate it. Yeah.
Absolutely, there's no question that this is NHS data.
Yeah, and it's a good question to see because there have been a number of other similar systems, the mobile ECG devices, where that's been quite a sensitive issue that's needed to be worked through. Issues obviously as well in terms of information governance, in terms of where that information's stored, and that is part of the specification work. Okay,
yeah,
question here from Jennifer Townsend, Anne. How do you think that dressing product use will be captured? Will it be via products being allocated a SNOMED code?
All products are already allocated a SNOMED code and also a DM&D code. So we are at that level, all products are already covered by SNOMED.
Okay. Question from Andrea. Are there any apps that are near to or are fully integrated with patient systems like System 1? We have looked, but are looking at double data entry for us as our organisation has to run reports from System 1 for CCG. It's a good question.
It's a great question, and there were many examples when I last engaged with a range of suppliers, which was probably about May time, when many people were actively engaged with System 1, EMIS and the other main suppliers to achieve this. So I'd be interested if we've got any suppliers on the webinar who've achieved this, if they could let us know. But we would envisage very much, as this is a national programme, that we can work with colleagues at NHSX, NHS Digital and NHS England Improvement to help support us drive the integration. Also, on our list is, once we've got our output-based specification sorted from the recent consultation, is we'd like to work with the system providers to understand that we're developing a standardised approach to the wound management digital systems, which should make it easier for them to do standard interfacing for us. We have yet to reach out to our colleagues in those companies, but it's on our pathway.
And there's a similar question from Jill, which I think is the same question. Can the NWCSP help with data from various GP compute systems used across the country and help the system companies, e.g. EMIS or System 1, etc., to adopt a national coding system and template?
We very much like to support that. That's on our to-do list. But we very much think we have a duty as an NHS, if you like, as a customer, to get our house in order and decide, for example, what are the right SNOMED codes, what is the data we want to collect, what is the specification that we can then take to these companies before and that we should do the standardisation and make it easier for them to help and work with us.
Yeah, okay. Next question from Kerry Grimshaw. In theory, the digital concept is a great plan, but we have areas where signal is non-existent in very rural areas. It's a good point.
We put in our specification that the systems should be able to work live when online, or if there is no signal, that you download a subset of, say, the patient record, and it automatically uploads when you get back into Wi-Fi areas. And that all of the vendors we've talked to have thought that was a standard feature and would expect to be developing that.
Yeah, certainly the one or two systems I've looked at do seem to be able to address that, but you've got to do the download beforehand, and then the data that's captured when you see the patient, that gets subsequently uploaded when you're back in a signal range.
Yeah.
Question from Ian Chetter. Have you plans to evaluate which is the best app for clinical use, given that there are several out there? Any plans to create the league table?
Absolutely not. We know that this is it's a relatively immature, exciting, emerging market. We think that one size won't fit all. What works best in one area may depend on the configuration and setup in the area. It'll depend what's already in use by either the community or the primary care or the secondary care trust about what works well for one person won't work for others. So we don't see that as part of our role. We see it's our role to say, what do we expect any of the systems to be able to do, and to describe that in a way that standardises the approach, supports people doing procurement and the people developing these products, and then allows the market to emerge and people select what is best for them locally.
Okay. Question from Jennifer Townsend. Do we have access to a comprehensive list of the SNOMED codes, or will they automatically appear when we build our template or tools, i.e. on System 1?
Well, we haven't yet defined what we think are the right SNOMED codes to use at a very high level for lower limb surgical wounds and pressure ulcers, and that we've done some starting work on what are likely to be the right codes to use, and we've got that high on our agenda to work with our analytical colleagues that we've just recruited, and with our implementation sites and broader stakeholders. So as soon as we've decided on the set that we're going to recommend, we can make that available, and that will include anyone who's developed a System 1 or an EMIS template and working with the companies, trying to make that available as standard. And if people are already doing this work, we'll be reaching out to them to share what they've done, so that if somebody's a front runner, we can base it on their work rather than having to restart.
Okay. Next couple of, I think the comments really rather than questions. So Rob Hollingsworth from WoundPad, we have NHS digital approved integration with EMIS System 1 and Vision. So that's just a comment from
Thank you.
WoundPad. And Sharon Scattergood, I'm currently trialling CaseFlow, which can take photographs and input patient data, which is accessible to the medical team, etc. So just an observation that. A couple of further questions here.
Okay, Mike, can I ask
okay.
that I haven't come across CaseFlow before, so if that person can send me the details, I can add it to our register on our website of products that we're aware of.
Yeah. Okay. So comment back to you there, Sharon, if you could pick that one up, perhaps email us. Sarah Fentiman, could you explain SNOMED? We are currently being approached by various digital systems. Should we hold on this?
And SNOMED is SNOMED is the coding system that has replaced READ in primary care. Any system, if you're being approached by somebody, it should be capable of accepting SNOMED codes. It's just one of the things that you have to do as part of your data input, is to decide which SNOMED codes you're going to use to enter your data. But it should be invisible as a digital product. It's somebody using the product won't see the codes, won't have to know anything about the coding structure. It's a setup feature. So you just need to check, if somebody's approaching you, that their product is able to accept SNOMED codes.
Yeah. Next one, suggesting a feature. Is there a system in development from Alison Costello? Is there a system in development that could be linked to clinician's PIN or ID to enable the trust to monitor usage of products for specific wounds? Good question.
Well, I think there's two questions in there. If it's a staff numbers PIN, I'm not sure any of them are at the moment, although that most IT systems now are looking at being able to use a smart code or a PIN to capture the staff. I'm not sure we're talking about directly linking staff to product use, but we would expect to be able to collect data on staff and on product use, and then it would be up to locally how people want to set up and run reports from their database. I can't see that it would be likely to be staff versus product, but anything is possible once you've got all of that data.
Another comment from Nasir, don't all wound care products need to get a green light by NHS Digital? Something about the regulation of the apps there.
Yeah, right. So there are all sorts of NHS standards. If people go to the website and can find and got involved with our recent consultation on our functional overview specification, we listed an awful lot of NHS data and digital and app standards that suppliers need to be compliant with. And then when we turn that to an output-based specification, which we make available for people to use for procurement selection and maybe criteria and weighting, there's a whole list of the standards that things need to comply with. So yes, it's highly regulated, and there are a lot of standards that suppliers of digital products need to comply with.
Okay. Next two are possibly comments rather than questions. Christine O'Connor said, possibly IM1 or GP Connect will enable some initial connectivity between systems in advance of API's APIs being agreed. Just a common observation.
Thank you, Christine.
And from Danielle Hartle, have you heard of Total Mobile system that our district nurses currently use? If not, I'll email you the details. So another system there, Total Mobile
Please email
system.
me the details. Please email me the system.
Yeah. So I think as a couple of comments have identified there, this is a still emerging market. There are a couple of products on the market now which look reasonably mature. We're aware of a number of suppliers who have got product launches in the pipeline. Interestingly, there's a number of the wound care product manufacturers who are also developing applications as well. So there's quite a lot coming at the market. And clearly the work that Anne's doing to make sure we've got a minimum specification for what we expect in terms of functionality and the way these systems operate, it's so important that we get that correct so that we can get certainly a consistency of the way data can be captured, and that the products can obviously do their job effectively. Okay, I think that's all of the questions that have been raised in that section. So if there are no further questions, we'll move on. There's one from Andrew about CCGs, which I'll come back to when I do my section. Okay, could we have the next slide, please? Okay, so just before we leave the data and information thing, I have a personal view that one of the challenges that this whole area of care has had, and why it's not got the attention that perhaps some other services have got, and perhaps the investment in this area that other services have got, is the lack of data and the inability to make the case effectively. I think that if we do capture this data effectively, it'll raise the profile of wound care very significantly, and that's got to be a good thing. So just that observation. Okay, sorry, back, next slide. So let's just recap where we are at the moment. Well, we've got national funding in place. NHS England are funding the National Wound Care Strategy for the next 4 years. It's not a huge amount of money. We wish there were more. It funds the core team to do the strategy development work, and it will fund a very modest amount of implementation. But it's good that we've got that support. We've got national champions on the board of NHS England. Ruth May, the Chief Nursing Officer, has been very supportive, and we've maintained regular contact with Ruth. Also, Matthew Wynne, who's the Community Services Director in NHS England, has been very supportive. He can clearly see how the work we're doing fits into the work that his directors have got planned in terms of community services transformation. We've got the business case for the lower leg pathway, and that's some of the data from that business case was showed by Una earlier, and that demonstrates that both patient outcomes and financial benefits can be delivered through a combination of service improvement, use of digital innovation, but also data analytics. So that case has been particularly helpful for us to both make the case at national level to make NHS England, NHS Improvement recognise that there's something here which not only improves patient outcomes, but also delivers significant cost effectiveness. We were very careful when we produced that case in terms of using terminology like cash releasing and non-cash releasing. There's clearly cash releasing opportunities where there are the opportunity to make savings on dressings. In terms of the impact on staff time, we didn't describe that as cash releasing because we know how pressurised community services are. So we've described that deliberately as a productivity benefit rather than a cash releasing saving. So just to make the point here, what we're not suggesting here is that there's big swathes of money to be cut out of staff budgets. Precisely the opposite. We want to make sure those budgets are protected, but make the case how the resources can be used more effectively. What we also produced as a byproduct of producing the business case was a template that can be used to support the development of a local case, and I'll come back to Andrew's question here in terms of CCGs and what sounds like a reluctance in her patch for CCGs to support a piece of work like this. You'll have seen from the chart that Una used to illustrate her presentation earlier, there is a small modest input cost required, but the cash releasing and non-cash releasing benefits that are generated subsequently far outweigh that initial investment that's actually required. And so we hope that template can be used by people at local level to produce a business case that may be considered by a CCG board, for example, or whether it's the ICS board or the STP board, to actually demonstrate in very broad brush terms the input costs that would be required, but the significant benefits that will generate as a consequence of that investment. So hopefully CCG boards who may be a bit more focused on the budget for obvious reasons will be capable of being persuaded. What we are trying to do here is a carrot and stick approach, in that what we want to hopefully do is make the case very compellingly and convincingly, which will bring local organisations online. But the work that we're doing with NHS England and NHS Improvement is also to try and make sure that we get policy steers from the centre to be incorporated in future planning guidance to make sure that the recommendations get implemented. It's perhaps not a stick per se, but I think some compulsion from central policy direction will be really helpful to supplement a local case of change that can be developed. So we're trying to use both avenues to make the persuasive case of why the strategy and its recommendations need to be implemented. So we've got there, and now the next stage then is to start thinking about the how and how the implementation actually takes place. Can we go to the next slide, please? So what we are currently involved in is recruitment of a first tranche of implementation sites. I mentioned earlier, we do not have a huge amount of money. I wish that we could provide funding for a significant wave of first tranche sites. In the first instance, we will be looking to recruit around about 3 sites. We will follow that up fairly rapidly in the new financial year 21-22 by a further wave of recruitment, but initially it will be a fairly small recruitment. The reasons that we want to bring in a first tranche, obviously we want to test those assumptions in the business case. I think from what you've heard in Una's presentation earlier, certainly in Mid-Yorks, all the assumptions more than stood up to the early piece of work, and we know already that there are a number of sites around the country who are achieving these fabulous results. But nevertheless, we do want to make sure that we can just retest those assumptions in the business case, and it certainly strengthens the case as we move forward subsequently. And it's something obviously that people in NHS England are very interested in, to make sure that the veracity of the numbers that we put in that business case actually stack up. Secondly, we want to look at what the blueprint or blueprints for implementation may be. There's a fairly complex piece of service change here, involving technology, involving different clinics, new ways of working, data analysis, production of information, and we do want to look at the different ways that this can be approached. We're not suggesting that there's one tried and tested methodology, so it will be very much about looking at the first wave of sites to see how they approach this problem, to take some learning from that, hence the third bullet point, so we can evaluate the implementation and hopefully take the learning from the first wave sites into subsequent second, third, fourth waves of implementation. And as I've mentioned already, from 2021 onwards, we want to make sure that we get policy levers in place from the national bodies to support widespread implementation. We had Sequin that was ready to go, and then COVID came along, unfortunately, so that looks like it's going to be delayed. Hopefully it may be launched in 2021, but if we've still got the tail of COVID, it may get pushed back further to 2022, but it's gone through all the internal due diligence process in NHS England, that sequence, which is ready to go. And finally, yeah, we want to get a steer to commissioning organisations, to CCGs, to commission in line with the recommendation. So again, Andrew, coming back to your point, we do want to make sure that the that CCGs, if they've not seen the light of their own free will, do get some compulsion from national policy telling them in as pleasant a way as possible what to do and why they should be implementing these recommendations. Next slide, please. Okay, so we've sent an invitation out seeking expression of interest in becoming first wave sites. That's gone out by AHSNs. It's on the website now. There's a suite of documentation that you can download. And as I said, we're seeking 3 sites to be part of this initial implementation cohort. Around about 3. We'll look at what comes back. If we think there's some really fantastic cases, we may see if we've got some financial flexibility. But what we don't want to do is dilute the resource we've got available too far. So we're trying to give a bit of punch to these initial 3 sites. But we'll see what comes back and how we can use the money as best we possibly can. But it feels like 3 is about the right number at the moment. Next slide. Requirements fairly straightforward, really. Hope that there's nothing too scary there. Firstly, obviously, a commitment and readiness to implement the strategy recommendations. Secondly, a full commitment to developing an implementation case that describes the resourcing timelines, planned outcomes. So from both commissioner and, sorry, it's hidden beneath one of my text boxes there, and patient perspective. What we're clearly trying to do here is make sure there's a proper methodology that underpins this so we can take it forward as a proper piece of QI work. So we want to make sure we get that assurance because that clearly gives it a better chance of succeeding. Thirdly, we obviously want to make sure all relevant local partners are supportive, not just the provider organisations, but obviously commissioners, primary care networks, I guess, are going to be big players, and depending on what your local governance decision-making arrangements are in place now, potentially full ICS STP supports as well, obviously. 4th point relates back to that second point. We want to ensure there's the use or adoption of a recognised service improvement programme management methodology with the supporting timeline, etc. We've suggested from a local academic health science network partner. We know they have the skills. That's not absolutely mandatory, if I'm honest about it. If you believe you've got in-house QI skills and capabilities, and I know that a number of the larger trusts have these, then that's fine. If you think there are other partners who can support you, equally, that's fine. What I would like to hope we could deliver, though, through working with the AHSNs is develop a repository of skills and knowledge in this area, such that when we come to 2nd, 3rd, 4th wave implementations, we've got people there who've been involved in the 1st, 2nd wave of sites who can use the knowledge and skills they've generated and impart them into subsequent implementations, which hopefully makes the whole process a bit easier as we get onto a subsequent piece of implementation work. And then the 5th point, obviously, the commitment to release frontline staff to undertake the training. That's a bit of an obvious one, really, isn't it? Okay, next slide. Further requirements, well, I think we've majored on the point, obviously, that the use of digital tools, including use of mobile technology to support the programs, will be an essential. Active engagement of service users is obviously a very helpful enabler to make sure programs of this nature are delivered successfully. How early implementation of strategy recommendations addresses health inequalities. So that's something that NH England have asked us about, in particular the angle on health inequalities. Further, to commit to work as part of an implementation collaborative. So we do want the early wave of sites to be working as a loose network with one another. That obviously makes good sense, doesn't it, to make sure that as people hit barriers, for example, in Site A, that's being shared with Sites B and C in terms of how to overcome those barriers. So hopefully we can develop an esprit de corps across that group. That would be really helpful. The commitment to evaluation that's already been mentioned, and also the commitment to assist in developing a blueprint for implementation. So to make sure from that evaluation we get some guidance in terms of how to make this process easier as we go out to wider waves of implementation. Have the next slide, please. I'll just bat through these. You can have a look at these when you, sorry, just go back one. When you can look at these when you download the documents if you're interested in becoming a site. Firstly, the basic detail capture, no mystery there. Next slide. Next slide, please. Partnership working, so we just want to get an idea of how the organisation operates and the people who will be part of the piece of work and their commitment to it. Next slide. So a bit more about the organisation, the commitment to releasing resources. Next slide. Data and information section, I've already covered. Next slide. There we go. So expressions of interest. There is a template, I think it's on the website, and they have to be submitted to that email address no later than, sorry, it's hidden under my one of my boxes, 5 p.m. on the 20th of November. We will look to shortlist them fairly quickly by Tuesday the 24th of November, and we aim to let applicants know by the 25th of November the outcome of that process. I guess thinking about it, that's dependent on how many applications we get. If we're completely inundated, those timelines may be slightly delayed, but certainly I think you can see the intent is to make sure that we can get the first tranche identified very rapidly so that we can get some implementation work happening. We know that COVID is a challenge, so we do accept that. Now, having said that, the work that was described at Mid-Yorks, that work was done in peak COVID period. So we know that it is possible, although we recognise that COVID can be a distraction. I took part in a discussion with a number of tissue viability nurse specialists a couple of weeks ago, and whilst some seemed relatively untouched by COVID, a number of them got the big level organisational pull on their resources, so we know that that could well be a challenge in the current COVID era, and it might be helpful just to reflect on that and perhaps provide some assurances in your applications in terms of how that might be managed locally. It may be that, you know, if there's a particular issue in individual economies, then it might be more sensible to wait for second or third wave implementation opportunities rather than going initially if you think that your organisation may be pulling on resources. We know that's a challenge. Okay, next slide. So the support that we are offering, so for those 3 sites, and we're trying to make sure we distribute them across NHS England regions. Each first tranche site will receive support of the resource, not so much the body, but the resource to enable the buying in of 1 whole-time equivalent of a senior implementation lead and half whole-time equivalent of a support person. That will be fully funded for 9 months and then 50% funded for a further 15 months. There will be some more resources being released in 21-22, so this is just the offer for the first 3 sites. Organisations that sign up for the first tranche implementation will need the commitments of minimum of 2 years for these implementations. And as the implementation project rolls out, the funding pattern will be replicated for the other 4 NHS regions, as I've just explained. There may be room for differing approaches. Our resource envelope is tight. We are constantly having conversations with NHS England in terms of whether that resource envelope can be flexed, although we know we've been very lucky to secure the resources that we have. But I think that the more we can make the case in terms of the benefits that implementation of recommendations being delivered actually can deliver, then hopefully it strengthens our ability to make the case for more resources with NHS England. But at the moment, that's what we can fund. Okay, next slide. I mentioned academic health science networks, and I have to declare my interest here. I work for the academic health science networks, but we do believe there could be benefits in working with them. They have the knowledge and expertise in terms of piece of pathway transformation, and they have the ability to support also digital technology, as well as do the work around data and informatics. So there's a set of skills there that may be brought to bear, although, as I say, that isn't a mandatory criteria. If you think you've got the ability to resource those skills elsewhere, internally or from other partners, please don't let that deter you from putting in a submission. Having said that, throughout the development of the strategy, we've kept the academic health science networks fairly well briefed in terms of the work that's progressing. And I know that a number of HSNs are already doing some small scale piece of work in this area. So hopefully there will be some skills that you can tap into there. Okay, next slide, which I think is the final slide. That's it. So any questions? I'm just going to perhaps ask Una to join me back again on the screen now. Let's just have a look, see if there's any new questions that have come in. So I'm just going to read through some of these in order. Hi, I'm a commissioning nurse and would like to be involved as a site to help support improvements area. Thank you, Sarah Fiore. Jennifer, asking for clarity, first 3 tranches to be funded to implement, hence the low numbers. Yes, quite correct, Jennifer. As I say, if we had more money, we would love it to be more than 3 sites, but we're trying to make sure that we get bangs per buck out of the limited resources that we do have. Will we be able to have a copy of these slides? Yes, a copy of the slides will be sent to everybody who's registered for this event today. We're also going to make sure there's a recording available. Please, will the private, volunteer and independent sector be invited to join the project? Yes, no reason why other organisations can't join in. I mean, ideally what we're looking for are NHS footprints, but those NHS footprints want to work with other partner organisations, and that's perfectly feasible. We're aware of at least 1 or 2 not-for-profit organisations who've got service models in this area who have delivered some stunning results. So this isn't just an NHS piece of work. Could you give us further details regarding the application process to become a first tranche site? Hopefully I've given you those, Ian, and the information is available on the National Wound Care Strategy website. Are the forms on the site or on the AHSN site? I'm pretty sure, Una, all the paperwork's on the site.
We posted them the end of last week. They should be there. Yeah, we've tried to make them easy to find.
Gillian Thorpe, do you have implementation sites in mind already? Absolutely not. We'll treat this as a completely level playing field. Obviously, as the wound care programme has developed, a number of people from all parts of the country have contacted us and expressed interest in becoming involved. But you know, we genuinely want to have a look at all sites who put in expressions of interest. So there will be no favouritism.
No. And also another interesting one is what we're really looking for is willingness and buy-in from across organisations, because we don't quite know what we're going to get. I'm sorry to be so vague on what it is we're looking for, but we know we've got to go for regionality, but we also want a mix of organisations. So we're not necessarily looking for the 3 who are furthest on in the process, because it will be interesting to have a mix of people, of organisations as to different progress, because we'll all learn from each other. What really is important though is that willingness to work across the different provider organisations, whether NHS or elsewhere. That's really, really key, because I don't know how we'll do that otherwise. But again, even if you can't get full buy-in from everybody at this stage, that doesn't stop you applying, because that will be one of the challenges, is how do we achieve that? So we are looking for a mix.
Do we have implementation? Perhaps a link to the application form. We've covered that. Kerry from Worcestershire, could you please let me know the top range of funding for the implementation lead post, please? I forget what we costed it on, Una. Was it?
I think that costed 8B, but it's not going to be a case of that person the money will be sent across to the organisation to pay for that. It's going to be a more complicated, well, not so more complicated, but that will require discussion and negotiation as the best way of where that post would sit. What's absolutely essential is they are tightly tied into the National Wound Care Strategy Programme.
are you looking to start in April 2021? Well, the resource that we have available, we have resource available in this financial year. So we would want to get the first wave sites initiated during this financial year. There is more resource available in 21-22, and it's an interesting point actually that in terms of whether some applications we are able to carry forward to a second tranche, something that perhaps we need to think of. So the sites aren't running in series, they are running in parallel. So we expect that the second tranche sites will be up and running whilst the first wave sites are in implementation progress, as it were.
The other thing I was going to say with that as well is obviously we can only invest financially in 3 sites, but if we've got other areas that we know are working, would like to be kept informed, then there's no reason why we can't develop some sort of collaborative, sort of like an outer circle. We're just going to have to see who expresses interest, and once we know a bit more of that, then we'll be in a better position to share that sort of information.
Yeah. Couple of quick questions here. East of England not mentioned on the expression of interest form. Oops, that looks like a mistake, Heidi. We'll rectify that.
Thank you. We'll check that. Sorry.
Minor point, which is actually a very good point. The template is in PDF. Can we have it in Word format? Obviously, yep. Yes, good point, Matt.
Sorry, error. Let me jot those down.
Question from Carly. Does it have to be STP buy-in or part of an STP? We've tried not to be prescriptive on this, Carly. Yeah, I guess it really depends on what the local governance arrangements are in your local patch. I personally happen to think that small is beautiful, and I think it'd be difficult to do a full wave of implementation on a complete STP footprint. And again, thinking about the resources, it may dilute them down a little bit too much. But you know, if STPs want to go for it and they can put their own resources in, then potentially yes. But I think ideally we're probably looking at old district type footprint, old CCG type footprint. Although you know, don't take that as absolutely read. If there are different footprints, if there are ICS footprints that are different from that and they work well for you, then that will be the right footprint for you to submit on. Alison Costello, keen to understand how suppliers can support with this, pathways, protocols, etc., and how to support clinicians with implementation efficiencies, etc. Una, any thoughts on that?
I think we're going to have to. Are we talking about for the application there? Sorry, Mike. What was the question again?
Just keen to understand how suppliers can support with this, pathways, protocols, etc., and how to support clinicians with implementations.
Yes, that's an interesting one. Actually, I was asked that last week, which is interesting. We haven't got strong views on how this has to be done. So if it's a case of an organisation will get some support from a supplier, then that's really up to that organisation. We'd obviously like it declared because that is part of the information we'll gather. But we are open to suggestions. Really, it wouldn't count against. It's how that support is used.
Yeah. And the expressions have to come from NHS organisations. So you know, suppliers are on this call, and I think there are 1 or 2. If you're looking at this and thinking this is interesting, well, you'll need to identify NHS organisations who you want to partner with to provide support for an application to go in.
And the application would need to come from that provider, not from the supplier.
Yes, obviously. Yeah. I think I've answered Nasir's question. Does size matter? Some will be small scale projects where others may be large scale. Yep, correct. Alison Schofield, as a TVN, I'm fully supported in being a site, but what level and who in the trust CCG do you need for the buy-in to it? I guess really, Alison, it depends on what your local decision-making arrangements are, whether it needs to go up to CCG board level or whether there's devolution to an appropriate level that can enable the organisation to be brought in. So can't really be prescriptive on that. What we obviously want to make sure is that we've got all the full commitment of local partners. What we don't want to do is work with a first tranche site and then find that, you know, 6 weeks in, a higher level of decision making turns around and says, sorry, we can't support this. So we do want to make sure that we don't hit issues and barriers of that nature. So can't answer that question, but I guess you understand where I'm coming from on that. Question from Stephanie, really interested in applying, but would like to do across our region. That is a primary and secondary and community across the region. So several organisations, how do we apply as a combined implementation site? Well, hopefully we've put the template together so that you can put expressions of interest in on that basis. So I hope there's the flexibility in the form to respond on that basis. I guess in actual fact, if it was just an application from a single organisation, we'd probably be quite concerned. We do want to make sure that there's full buy-in from organisations. Now, one of the issues obviously is that the NHS structures vary so much from health economy to health economy. In some now, we've got whole integrated trusts. In some, there are community services providers still. Some have got, proper governance arrangements with ICSs being the decision-making body with all the partners around the table. Primary care networks play a part. So really, in completing that part of the application, I guess you really need to describe how your local system operates and how your local system will be supporting the application and the process of implementation. So we don't want to be too prescriptive, but you will need to just advise us really in terms of how your local systems operate and therefore how the implementation will be supported.
Yes, can I just add to that? The form, we've obviously from our point of view, we need to just communicate with one applicant because otherwise it gets complicated. So whichever organisation would take responsibility for the application, that's how person will communicate with. But we have tried to make it possible on the form so you can tell us about what you're proposing as a group so feel free to use that form as flexibly as you want to get that information across to us. And the other thing is, remember, this is the first expressions of interest. We appreciate, obviously, if there are organisations that can say, yes, we've got X, Y, Z and ABC all signed up and here are the letters proving it, that will obviously be a stronger application. Somebody says, I've just started talking to somebody. But we appreciate this is the first expressions of interest. We will need to turn this around quite quickly, but we will be going back to you, whoever's successful, to say, can you tell us a bit more so that we get that information? But we just don't know how many applicants we're going to get, and that's why we felt we needed this expressions of interest first. But then we will be having further conversations following towards the end of November.
Yep. Further points, given the challenge of COVID-19, has there been any mitigation been brought into plans for those that may apply? Well, I think I've already covered that point. Are AHNs expected to be partners on the application? Not necessarily. If you've got one, that's fine. But as I say, there may be other implementation partners, or you may have that implementation capability in-house as well. So that's not a mandatory requirement. No. SCP engagement valuable for rollout process as project develops. Thank you, Christine O'Connor. Very much agree with you. Jackie Dark, if first tranche is the blueprint for the development of these services, would the second tranche be started before the first tranche has made its recommendations? Good point, Jackie. In an ideal world, I guess, yes, we would make sure that the tranches were sequential, but we are very keen to get moving with this. So we may have to do some really rapid learning on the hoof here. What we don't want to do is delay a second wave unnecessarily to get the learning out from the first wave. But so it may be that we've got to produce that learning as a series of continual findings as we go along. That's a good point that we'll perhaps need to think about once we've recruited the first tranche sites and how we actually make that feedback work effectively. Christine O'Connor, governance would need to be transparent in any arrangement with suppliers. Yep, absolutely, good point. Sarah Pankhurst, I'm Steph, it's a single CCG area. There you go, so that's probably the footprint you need to submit an application on. Heidi Sandoz, you mentioned patient engagement in the slides. Is this something you expect in place at the beginning, or can it be developed during the implementation?
Yes, I think that's really cool. Yes, I think it's great if you happen to have a handy patient group ready to go, but that's maybe unrealistic. And one of those will be, how do you actually engage? What's the best way to engage? So it's all part of our learning. A lot of this is around the willingness, and not just the willingness, of course, but having a reasonable chance that you've got a vague idea how you would want to do this, but we're not expecting everything to be cut and dried by the 20th of November. There's going to be a lot of learning along the way.
Another point from Christine O'Connor: be good to consider a number of implementation sites needed to deliver strong traction across the country. It's a good point, Christine. The more the better. I think I've made the point fairly clearly in terms of why we've unfortunately been limited to 3 in this first wave, but certainly if we can get an early second wave going, then potentially we do have a bigger cohort which will provide that traction as you suggest. Okay, I think that's all the questions been answered. Una, I don't know whether you've got, or Anne, you've got any concluding summary points you wish to make?
Shall I go first?
Yep.
Just to say, I'm delighted. There's been nearly, at times, 200 of you on this call. It's only dropped. The lowest, I think, now is 180. And I know how busy you are. And thank you so much for your enthusiasm with this. Please, if you can, we really want to hear from you. We're trying to work out what's the best way forward. It's not that we're completely without ideas, but please don't, if you think this is something you'd like to be involved in, please put in an expression of interest. We'd love to have that conversation with you. So if you think you can, this is a piece of work your area is really interested in, please put an expression of interest, because then at least we know you're out there and there's enthusiasm. So please don't hold back.
Thank you, Una. Anne, any concluding comments?
I just agree that if you haven't got the digital technology but you're interested, then put that in, and it won't rule you out at this stage. We want everyone to come and play, that we can work with and learn together. Okay,
thank you, Anne. And finally, thank you, I guess, to everybody who's joined this. I know everybody must be enormously busy, so we do appreciate the time that's been taken. This will be, it has been recorded, so an edited version of this webinar will be on the web very shortly. The application process is on the website. There's a whole stack of other resources on the website as well. So even if you've not got the address, just Google National Wound Care Strategy, you'll find it. So please take the time to look at that. Thank you for those who have answered the questions. Those have been very helpful to stimulate the discussion as we go along. And thank you also to Francis, Simon, and Emma, who were behind the scenes making things run as smoothly as possible. Thank you. Goodbye.
Goodbye. Thank you.